All right. Last time we went through the sympathomimetics. Now we're going to look at the other way. Other than beta 2 stimulation that we can get bronchodilation occurring, and that's the blocking of the cholinergic receptor site for acetylcholine in the muscarinic junction. We know that the parasympathetic nervous system does the opposite of the sympathetic system. So in this case, stimulation of the vagus nerve, which is a parasympathetic nerve, leads to bronchospasm, increased mucus production, an inflammatory response, and a slowing of the heart rate and the lowering of the blood pressure. Okay, so after stimulation from the sympathetic system, the rest and digest would be the parasympathetic stimulation. However, this can occur without that sympathetic being stimulated before. So, and now what this is going to take place on is basically this bottom portion, where something causes a reduction in cyclic 3', something causes an increase in the cyclic GMP right here. From a cholinergic receptor being stimulated, acetylcholine causes an increase in cyclic GMP, which then causes bronchoconstriction to occur because of mucosal swelling, because of bronchospasm, etc., etc., etc. Okay? So with these drugs, we're going to do are trying to block that cholinergic receptor. We don't want that receptor site to be stimulated. And that increase in cyclic GMP, if that does not happen, then we end up having no bronchoconstriction happening, which is basically showing all those steps that are involved there. So again, more parasympathetic stimulation leads to bronchoconstriction. So just like we had a little drawing in the beta agonist situation, we have the same thing here. Here I have an anti-muscarinic agent, an anticholinergic agent, same thing, right? That blocks or inhibits that muscarinic receptor. So it ties up the spot where acetylcholine would be stimulating. If that site is tied up, then there is no ability to have an increase in cyclic GMP, and rather just the normal process will go through. If that wasn't inhibited, then we would have the production of guanyl cyclase, the equivalent of adenyl cyclase, which converts GTP into cyclic GMP, and which promotes bronchoconstriction as that level rises. Okay, so it's just like on the beta adrenergic side, where I have adenyl cyclase stimulating, adenyl cyclase being created, which causes the conversion of ATP into cyclic AMP and bronchodilation. Here, if the site was not blocked or not inhibited, you would have guanyl cyclase converting GTP into cyclic GMP, and an increase in cyclic GMP would cause bronchoconstriction. Because I block it way at the beginning, none of that bad stuff happens. Does that make sense? So instead of stimulating the production of cyclic AMP, I'm preventing the production of cyclic GMP. Another way to gain the same exact thing. Both of them cause bronchodilation to happen. In one case because of a stimulation, in one case because of a blockade. These are called backdoor bronchodilators. Okay. Also known as parasympatholytics, also known as anticholinergics, also known as antimuscarinics. Could you give me about another 47 names to memorize? Thank you very much, Rick. But they all mean the same thing, and you'll hear them referred to all different ways. So we said they block the parasympathetic nervous system by blocking that muscarinic receptor site. The interesting thing about this is that the majority of these muscarinic receptor sites are in the larger airways as opposed to the more peripheral airways. where we said the beta adrenergic receptors had their biggest effect on the small to medium-sized airways. These medications have their best effect on the larger airways. And when they attach to the muscarinic site, they prevent acetylcholine from attaching, and therefore it prevents the formation of cyclic GMP. Okay. So here's our 2 acetylcholine junctures that happen, and we said that if this was not inhibited, we would have increasing in that cyclic GMP production, causing a narrowing of the airway. Because there's no cyclic GMP being produced, there's no bronchoconstriction that happens because it's blocked. My anticholinergic agent blocks that nerve or that receptor site from being stimulated. I said the same thing about 47 different times, different way each time, but hopefully the message got across. Anticholinergics induce bronchodilation by preventing bronchoconstriction. It's kind of a backwards way of thinking, but that's why they're backdoor. 3 primary agents, and there actually is a 4th one in here that I'll throw in. Atropine, ipratropium bromide, tiotropium, and we'll find that aclidinium, how it's pronounced, is another one, but we'll talk about that. Just like epinephrine was the prototypical catecholamine, the prototypical parasympatholytic is atropine sulfate, also known as, or comes from the origin of Atropa belladonna or Datura stratonium, the nightshade or Jimson weed. It has multiple uses besides being a bronchodilator. In fact, we rarely, if ever, use it as a bronchodilator. But again, it's the one that's the basis upon which the rest of them are built. We primarily use it in cases for dysrhythmias, and you can cross out asystole because they pulled that out of the ACLS algorithm. So if I got a slow heart rate, blocking a parasympathetic system will cause that heart rate to rise. Because if you think about what parasympathetic does, it slows it down. If I give a drug that blocks that, it's going to speed it up. And you may remember belladonna from Practical Magic if you've watched that movie. You guys haven't seen it? Mm-hmm. Next Halloween, that is your assignment, to watch Practical Magic. It's a great witch movie. Okay, leave it at that. One that we will encounter is ipratropium bromide, also known as Atrovent. It's available as a solution, as an MDI, a nasal spray. It is quick onset with a pretty decent duration of action. And you may encounter patients who say that they can't take this medication as an MDI because they're allergic to it, which was true in the CFC formulation. It actually contains soy lecithin, so those people who had peanut allergies had an allergic reaction, which is kind of a bad thing if you're trying to relieve bronchoconstriction to create it. The new version, the HFA version, which is all you're going to end up finding nowadays, does not have that problem. So patients might think that they can't take it, but under the newer formulation, it's not an issue. Another one that you probably have encountered on TV is Spiriva, the guy with the elephant sitting on his chest. It's a once-a-day dosing. It has a capsule. It's in a blister pack called a Handihaler. We've talked about this before. You take it out of its blister pack. You go ahead and place the capsule into the little chamber. Close it. There's a button that you push on the side to go ahead and puncture it so that the dry powder can be inhaled. It's about 18 micrograms, inhaled once daily, and it's again would be classified as a as a maintenance drug because it doesn't have a quick onset, but it's designed to last for a full day in duration. This is the new one that I mentioned, aclidinium bromide, and also known as Tudorza. 400 micrograms twice daily. Again, long maintenance. It has a dry powder inhaler. It's known as a press air, and it works by blocking those muscarinic receptors in the airways. Same as all the other anticholinergics do. And here's a look at what the little device looks like. It has a dose counter, which is nice. It has a little window. And you basically push the green button all the way down and then release it. And then once it's not being, you don't hold down the button. This portion here of pushing the button down just basically releases the next dose to be inhaled. It's a dry powder that is then inhaled in. And if you do it correctly, a little green light will show up, or a little green window will show up. Ooh, we did it correctly. And you can see the number of doses that are remaining in the process. And it goes down by tens. And once you get down below 10, a little red band will pop up to show you that you're almost out. I guess there's another one I forgot about. Umeclidinium. Again, another DPI. And this is the one that we were talking about that's available alone or in combination with bilanterol as Anora ellipta. I don't expect you to know these medications as much as I want you to pay attention to. Just like with the bronchodilators, I said these newer agents were home agents. They're once a day. You probably won't administer them inside the hospital, but at least you should know what they are. So if you're looking through the patient's chart and you see this. So here we have a combination of a long-acting beta agonist, vilanterol, being mixed with a long-acting anticholinergic, umeclidinium. And again, these are not rescue medications. So you probably won't encounter them at home. Each time this is directly off of their product lit. The inhaler contains 30 doses. Each time you move the cover, a clicking sound can be heard. So the dose is ready. And then once you go ahead, after the cover is closed, if you do that without taking the medication, you lose that dose. So the discard date is 6 weeks from the date the tray is opened. This is what it kind of looks like. There's a little tray that comes in with the inhaler that has the medication in there. And there's desiccant to prevent crying because it is a dry powder inhaler. Or I'm sorry, to absorb moisture. Here's what the device looks like. It's kind of like the Advair discus. A little lever you slide and clicks and gives you a counter. So, as a review, alternative way other than beta stimulation to accomplish bronchodilation is to use an anticholinergic. These are hitting the muscarinic receptors, and these are usually found in the larger airways. Other things that can occur from anticholinergics are the opposite of what you would expect to see in the case of parasympathetic stimulation. Parasympathetic stimulation also increases the amount of secretions. Here it reduces it. It also causes constriction of the pupils. Here it dilates it. It also causes slowing of the heart rate. Here it increases the heart rate. So everything that the parasympathetic system would do, this does the opposite. An anticholinergic is going to do, it's going to cause the opposite effect to happen. One interesting thing is dilate the pupils. There's been case reports of someone using a mask delivery system, delivering ipratropium bromide, and just the mist being created caused the eye to have bronchodilation, or to have pupillary dilation, which is secondary to the medication being administered. So, got to be cautious about that. And these are the ones the three primary ones that I want you to know, although there are a couple of other newer ones that are on the market that you might encounter. Some combination therapy that are situations where I have albuterol and ipratropium bromide. Combivent, I don't. It's the last I heard is that they were looking to get an HFA version of it because it's one of the more popular drugs in the ICU to be given to patients who are on mechanical ventilators, and you can give a unit dose, but it's a whole lot more time consuming to administer. That's why they like the Combivent. And studies show superior efficacy of this combination of a short-acting beta agonist and a relatively short-acting anticholinergic than to either of them by themselves. What do we call that? That's synergy. Another combination is ipratropium and phenadrol. This is called Barrel Respimat. I don't see that it's been released as of yet, although it looks like they're getting close to it. But that Respimat is one of those weird inhalers we talked about that doesn't need any propellants. So if you go back in the notes from Module C, they talk about the Respimat inhaler. We can also, like I said, they get complementary sites of action. So anticholinergics are the much more larger airways, where sympathomimetics are much smaller airways. One stimulates the 3' 5' AMP production. One blocks the production of GMP. And beta agonists are going to peak a little bit earlier than the peaking of the anticholinergic, so they kind of work in different timetables, but they both have the benefit of having a long duration of action, upwards of 6 hours. Other combinations that you can get, now instead of mixing a sympathomimetic and a anticholinergic like we just showed, I'm going to mix a LABA, a long-acting beta agonist, and an inhaled corticosteroid. We'll find that in the management of asthma, the initial therapy is inhaled corticosteroids with a rescue short-acting beta agonist, and then gradually we'll add in, and as the disease worsens, we'll add in an inhaled corticosteroid. Has Jeannie got into asthma? The EPR3 yet? Okay. You will end up seeing this. Same is true with COPD. If you take a look at the gold standards, the initial mechanism of therapy is to have inhaled corticosteroids with combination with a long-acting beta agonist. So the first one on the market that was there was Advair, using the discus, twice-a-day dosing. Fluticasone was the inhaled corticosteroid. Salmeterol, or Ceravent would be the trade name, but in combination it's known as Advair. And we get the benefit of both, the reduction in the inflammatory process and the bronchodilation. Again, these are long-acting agents. These are not rescue medications, and patients need to be reinforced that they're only done. They should not be used in an acute attack. Another example of a combination: formoterol, LABA, budesonide, inhaled corticosteroid known as Symbicort. We'll find that budesonide can be administered by itself. It's known as Pulmicort. Formoterol can be mixed with mometasone, which is known as Dulera. Mometasone, again, here is your inhaled corticosteroid. And then we just talked about Volanterol, new long-acting beta agonist, and Fluticasone, again, being your inhaled corticosteroid, known as Breo-Ellipta. I think some of these we do have on our list of medications for Wednesday's exam. Is that correct? So now you know kind of how these pieces fit together. Where do they come from? Yeah.
I see a lot of drugs on there, obviously a lot of dosages and stuff. Beyond the 8 that we have for now, do we have to know the rest of the dosages or something?
No.
So just focus on if they're
or steroids. Xanthines, also known as methylxanthines, because we can't just have one name. My God, that would be terrible. These are what I'm going to call side door bronchodilators, and these are the ones that are becoming a little bit more interesting as time is going on. We see xanthines or methylxanthines in all kinds of things. Caffeine is an example of xanthine bronchodilator. In case you didn't know, that was a substance in coffee. Theophylline was a substance in tea. And theobromine is a substance in chocolate. So they all do have effects on not only the heart rate, but also on bronchodilation. And these guys work in the mechanism of breaking down that cyclic 3' 5' AMP. If you go back to that initial chart, what we ended up seeing is that 3' 5' AMP stimulates the smooth muscle to be relaxed. We get bronchodilation. It is broken down into a substance called 5' AMP by an enzyme called phosphodiesterase. So if we give something that's a phosphodiesterase inhibitor, we end up getting bronchodilation longer because it's not broken down. Does that make sense? The cyclic 3' 5' AMP will continue to stimulate the smooth muscle to cause relaxation because the levels stay high if it's not being broken down by phosphodiesterase. Okay. We're not entirely sure how this all process works, but this is at least the theory. And these phosphodiesterase inhibitors, theophylline's the classic one. There are newer ones coming onto the market, but I'm not going to have you guys know them at this point in time. So here's our methylxanthines, and they work there by blocking phosphodiesterase and not allowing for 3' 5' AMP to be broken down. I don't know why I got that in. And we'll talk about some other things related to the mast cell and calcium at some other point in time. It's no longer a first-line drug. We used to use it a lot. It can be used as an oral medication for the maintenance of COPD, although typically is not. If you look at the gold standards, there is the option of using theophylline in there. The problem with it is it's got a low therapeutic index. Okay. Not a real strong bronchodilator. It is a very strong diuretic, though. So that's the good news. Has an added benefit there. And, yeah, leave it at that. Lots of side effects, some of which you don't want. Interesting is the use of caffeine is utilized for something we're going to call apnea prematurity. So babies that are born premature typically have an underdeveloped neurological system. Part of which is that they have prolonged periods of apnea, and just giving them some caffeine seems to prevent that from happening until their neurological system can catch up with the rest of their body. So that's kind of an interesting use for it. Again, they're available a bunch of different ways. I would like you to know this medication, theophylline combined with a substance called ethylene diamine, don't even know that. This is known as aminophylline because you will encounter that. It's an IV medication that can be used as an adjunct to other bronchodilator effects. Again, these have very slow onset with long durations because of that therapeutic effect being an issue. Patients who have liver disease and renal disease got to use real caution in it. And we want to have a blood level in these people when it's in use of 5 to 15. You get closer to 20 micrograms per milliliter, and you should know that, by the way. 5 to 15 is the desired theophylline level. What would the normal theophylline level be? 0. Duh. But the therapeutic range is 5 to 15. Okay. And these are some examples of some that you may encounter. Theo. Gee, maybe it's a theophylline-based drug. Fill-in. Aminophylline. recognition. You'll encounter patients who are on, especially physicians that may not be up to snuff on the management. Some of the older physicians haven't quite adopted some of the newer medications out there. I still use it. It's okay. And here's an example of something called Dolirest. Again, not a medication we're going to administer, but this is a phosphodiesterase 4 inhibitor. So these are one of the newer medications that a patient may be on as an oral medication that prolongs that action of cyclic AMP and has been shown to reduce the risk of exacerbation. And it's just a 1 pill a day kind of a process. So we're getting all the benefit of all these drugs now being maintenance once a day. Okay, let's talk about combining medications. You can give a front and a side together. You can give a side with a back, a front with a back, a front, a back, a side, all together. They're all working in different areas, so they can be given together. In many cases, they're synergistic when given together. You never give two front doors. The exception being a SABA and a LABA, because one is short-acting, one is long-acting. Okay, so those long-actings like salmeterol or formoterol can be given in combination with albuterol. Some people use caution formoterol with albuterol because formoterol does have a relatively quick onset of action. Give you an example, tell you a story. Was giving this lecture to one of the students, and this one young lady said, "Well, I give my son labobuterol and albuterol all the time together." He said, "Were they ordered by different physicians?" Yeah, they were. Pharmacists should never have dispensed them both to you. You may want to go back and reassess this. So I said, is your child a little high-strung, a little bit jittery? She goes, yeah. Stopped one of them. Everything was fine. No two back door, no two side doors. So, can I give Alupent, Atrovent, and Theophylline, assuming I can find Alupent? Yeah, that'll work. How about Venlafaxine, Maxair, and Atrovent? No. Provenal, Atrovent, and Aminophylline? Atropine, Formoterol, and Atrovent? Theophylline, Zopanex, and Atrovent? Venlafaxine, Atrovent, and Brethine? Good luck finding Brethine. Salmeterol, Venlafaxine, and Atrovent. That works for me too. Okay. Just making mention of diluents. Typically, the diluent we use is isotonic saline. That's typically when we're mixing medications together. We'll put we'll have the medication, and then whatever the balance is usually normal saline, which is isotonic in nature. There is the possibility to nebulize hypotonic saline or hypertonic saline. If you remember, hypertonic saline being placed in the airway, the high concentration of salt will cause the water within the cell to move out of the cell into the airway. This was what we could use as a sputum induction agent. So if somebody's got a dry, non-productive cough, but I want to get a specimen, I can give them a treatment with hypertonic saline, usually a 3% solution. It will cause the mucus to become more plentiful, and hopefully they'll be able to get a sputum specimen. Bottom line, best way is to keep a patient well hydrated. If somebody's dehydrated, as you'll find, they'll end up becoming a whole lot harder to have mucus being expectorated. Assessing the benefit, especially of beta agonists, we want to look for no alterations in vital signs. Heart rate should not go above 20 beats from the pre-treatment state. Subjective response, in many cases, that's especially in kids, that's what we often use because they can't do a peak flow. And I think this is where I'll stop. That's for you, Nikki.